Health Matters. This is the second session in our series. I want to let everybody know that this is being recorded and it will be posted to our learnabouttreatment.org, as well as the presenter's slides. Next slide, please. Some Zoom housekeeping. Please mute when you're not speaking, and remember the audio and video controls are in the lower left corner. Since it is being recorded and it will be posted to our website, we ask that all questions come through the chat and the presenters will get to them at the end. If you have any technical issues, feel free to also use the chat. Next. I would like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. And this is the second part of our three-part series. This presentation is on wound care and skin health. If some of you were in Spokane, you already know these amazing people. And so please join me in welcoming them. And I will hand it over to them to introduce themselves and talk to you guys about skincare and wound care.
Thank you so much. Thank you for having us. I'm Hailey. I'm one of the nurses with CHAZ.
And I'm Emily. I'm one of the nurses on the CHAZ Street Medicine team.
And today we're just going to kind of go over some wound care topics, kind of the basics in wound care, and go over kind of barrier solutions and best practices that we've come across as we've been doing this work. Okay, started. So some of our training goals for today is just to kind of go over basic principles of wound care, particularly in the context of substance use, focusing on what we can do for people while meeting them where they're at. We recognize that not everybody in this kind of talk today has a medical background, and that we all have different scopes of practice. So as I kind of go over things, please just be aware of your own scope of practice and what you're able to do within that. And then the ultimate goal of this presentation is just to kind of teach everybody just routine basic wound care that we teach even our patients, as well as when to kind of notice infection and the signs and symptoms, and when to seek medical attention. We're also discussing the barriers to care and how that can affect wound healing. And then we're going to go over a case study that showcases how we worked around those barriers. As a disclaimer, we're talking about patients that are unhoused and endorse substance use, but we are aware that not every patient that is unhoused uses substances, and not everyone that uses substances is unhoused. But being both unhoused and using substances can put those patients at an increased risk for wounds. To start it off, just some basic wound care practices. This may be new to some or review to others. And while there's a lot more to wound care than these basic principles, these are things that I tell everyone about in order to help just care for basic wounds. The first goal of any wound care is to keep it clean or get it clean. And sometimes it's easier in theory than in practice. Encouraging patients not to pick at their wounds or uncover it too often. Again, that's easier said than done for sure. Providing them with clean dressings or gloves or ways to clean their hands so that when they're doing dressing changes, it's as clean as possible. It can be really helpful. And then encouraging them to kind of just, whenever cleaning a wound, to use either a wound cleanser if that's available. If not, there have been a lot of studies, and basic soap and water works well too, as long as it's clean, potable water, or just water can help with cleaning out wounds. I don't encourage the use of hydrogen peroxide or anything like that. It hurts, and it's not ultimately very useful. And then next is kind of just controlling the level of moisture. In wound care, it's kind of our Goldilocks principle. So not too wet, not too dry, just right. This can be accomplished oftentimes with a good dressing. So kind of following into the next one of, keeping it covered as best we can. That's easier said than done for a lot of wounds, especially depending on the location. Hand wounds are terrible to kind of keep covered, same with the foot wounds, or toes in particular. So that's kind of where some of the healthcare professionals are getting them kind of in with a wound care specialized nurse can be super helpful because we kind of have those tips and tricks and fancier wound care supplies that we can kind of give patients so that they're able to keep it covered appropriately so that it has a good level of moisture, and kind of the coverage helps keep it protected, keep them from picking at their wound as well, that's good. And then encouraging them to monitor their wound, mainly their dressing. I try to get my patients to kind of keep it covered for as long as possible and just kind of watch the dressing. If they notice that the outside is kind of becoming soiled, or they're seeing drainage come through the dressing, then it's time to change it. But otherwise, the least often we can change it, the better, for certain wounds. And then also they can monitor for signs and symptoms of infection by just looking at the skin around the wound. And then kind of going over the basic wound care tips, I always like to mention that a lot of times these are really good starts, but if we don't address the cause of the wound as well, that the wound has a harder time healing if that cause has not been managed or removed. So if someone has like lower leg swelling, it's really hard to resolve the wound without also addressing the swelling. So working to kind of slowly get the patient in to a healthcare team that can help address that, it can be really, really useful to help with the wound that's there and prevent any from occurring further. And it also brings up what a lot of us already know. It's really hard to address, acknowledge, or manage a wound or your overall health if you don't have your basic needs met first. So not having a place to stay, a phone, consistent meals to eat makes it hard or nearly impossible to give the time or energy required to care for their wounds or to mitigate the contributing factors. So helping patients even just manage and kind of resolve some of those issues really can help improve their wound and their wound outcomes, and can be kind of part of basic wound care. It's just supporting the person as a whole. And my goal when I meet someone is to really just treat them first and kind of address the wound as like a secondary problem. And really, if it heals along the way as we're trying to get the person as a whole feeling better and kind of in a better situation, then that's fantastic. Um, kind of just addressing wounds. So how I go about kind of chatting with patients about wounds and addressing the wound that they have. To start off, wounds can pop up for a variety of different reasons. It can be as simple as small as a scrape or a bug bite, or as complex as a large amount of frostbite to a limb. There's lots of contributing factors to why a wound pops up, and why it worsens and why there can be delayed healing. Drug use can be one. It can affect blood flow to their extremities, which can impede the ability to heal. Wounds, really to heal, we need good blood flow to that area. It brings oxygen and other supporting white blood cells, red blood cells to help with healing. Without that, it really hinders its ability to heal. As well as if anyone's doing injection drugs that can introduce bacteria into the tissue and bloodstream, either causing a wound or if they have one already, making it worse. And then if people are experiencing homelessness or unhoused, often they have a higher rate of wounds and infections due to a multitude of reasons. Some we can probably already think of: the exposure to elements, lack of access to running water, clean clothes, nutritious food, as well as often having to stand or walk for long periods of time. And as a nurse in the community health field, I've learned how to approach the topic of a wound with patients and how to kind of navigate their SDOH issues that come up. Oftentimes patients won't want to initially show me their wound, and I fully accept that. I don't Really, push that or ask them to show me it. That can be for a variety of different reasons, being their comfortability, or I'm just kind of meeting them out and about in the community and no one wants to just whip out their wound in a public space, which is fully valid. And so usually I'll just try to ask them some leading questions, such as, how long have they had it? Do they feel like it is getting better, worse? Um, is it staying the same? What they've done for it? What if they've seen anybody for it? And how it's impacting their day to day. Those questions can kind of help me understand, especially in my wound care role, what dressings to give them, but also understand the patient's level of understanding about their wound, what they've tried before, who they've kind of engaged with to get support for their wound care, and how I can kind of help them navigate their wound. And once I do kind of gain their trust, and they allow me to help with their wound care, I always ask them what their goals are, because my goal as a wound care nurse and healthcare professional is always to get the wound to heal and get the person healthy again. But sometimes that's not the initial goal of the patient. Their goal could very much be just that they don't want it to smell. That's the part that's bugging them the most. Or their goal is that the dressing changes aren't painful or they're simple so that they can do them themselves because they just can't get into a clinic or routinely meet up with healthcare street med team as much. And if that's the goal, that's kind of what we work on, and help mitigate that. And then I also always make sure patients know what I'm doing when I'm doing their wound care. So I always make sure to let them know if I'm going to be removing the dressing or like where I'm going to kind of place my hand or touch them. Oftentimes patients can have had negative experiences with their wound care, especially if they've had the wound for a bit. Sometimes people just kind of go right in there and take the dressing off, and they don't have time to really tell them like, oh, this is really painful, or you need to take it off in just a certain way. And so I really do kind of go slow and make sure that the patient is fully aware of kind of what I'm doing and what I'm kind of thinking and what I want to do for their wound. And I also always make sure to kind of discuss my plan for their wound, what I want to put on there, just so that they really have input into what I'll be kind of recommending for their wound care. And it's always centered around what they're able to do, what they're comfortable with, and that it's meeting their goal for the wound. And that kind of often helps build trust. And we slowly work our way towards my ultimate goal, which is getting it healed. And many of the wounds that I see often fall into the chronic category. So the wound's not healing within a normal time frame for one reason or another. And oftentimes I find that falls into kind of the category of the patient's not having their basic needs met. They're not having that kind of social determinants of health support. And without that, wounds can take significantly longer to heal or may not heal. People can have chronic wounds for many years. Wounds often take a back burner to a lot of their other needs. So kind of the need for food, safety, housing, warmth, and helping people meet those needs really can have a trickle down effect to healing their wounds. So while, you may just be out there handing out, some Band-Aids and antibiotic ointment, and it doesn't necessarily feel like you're doing a lot. If you're doing that and then also helping them and kind of just supporting them as a whole, that can be really helpful for their wounds at the end of the day. And then while I'm talking or seeing patients, I will also kind of bring up and take that as an opportunity to discuss ways to prevent them from happening. So as I discuss with them, I can see, how did this wound occur? How can we keep it from happening? Some ways may be, giving them resources for needle exchange, making sure they have the ability to get their skin nice and clean if they were to use needles. Making sure they have access to kind of clean equipment, if they're ever ready for it, SUD treatment options and kind of supporting them within that. If they have lower extremity swelling, help them to elevate their legs, get compression socks if recommended by healthcare professionals, and then assisting with them getting into a respite bed and providing them with clean socks every time that they come in. And then some of the signs and symptoms for infection that are kind of good to know. Spreading redness. So the area around the wound is just getting really, really red, and it's kind of spreading out or up the limb, especially if it's a dependent leg wound. Any increased swelling, so not only swelling around the wound, but slowly that whole limb or section of the body is becoming more and more swollen. Any increased warmth. So the area around the wound is very hot to touch. Sometimes it can be hard to tell. I chronically have really cold hands. So oftentimes everybody feels warm, especially when my hands are freezing. And so I will either leave my hand there for a little bit, or I will kind of touch an uninfected, like say it's the right leg that's kind of has the wound and I think it's warmer. I'll touch the left one with the patient's permission, of course, to just kind of see if I can tell the difference just after touching the two to be like, oh, this is a lot warmer than your other leg, and you're not just warm as a whole. If there's increased drainage, so the patient's like, yeah, all of a sudden it just started leaking like a sieve. And I'm like, yeah, that's not fantastic. And then if that drainage has changed in color, so if it's become thicker, it's yellow, white, and or green. Some drainage can be, that's a sign of infection. Regular drainage can sometimes be kind of yellowish, kind of pink tinged or clear. And that's fairly normal for a wound. But if it has become thick, yellow, white, or green, that is a sign of infection. And worsening smell. So oftentimes patients are very aware of their wound. So I will just ask, does this smell worse than it usually does, or is this about the same? And they usually they know, as well as increased pain. Some pain with a dressing change is to be expected. Patients likely kind of already know that that's their normal level of pain. But especially if they start commenting like, oh, this hurts. This hurts a lot more than it has. It hurts even when I'm not touching it. It's just become achy and painful without me even doing anything to it. All of those are kind of signs, and especially when you combine a lot of them, they're definitely signs that the wound is worsening, becoming infected, and it's time for them to be evaluated by a healthcare professional. And then on the next slide, I'm kind of when to refer to the ER. So the other ones are signs and symptoms of infection. And so that's definitely time to get them engaged with the healthcare professional, be that urgent care, PCP, ED, someone, whatever kind of the quickest route may be for that patient. But specifically when to refer to the ED is when they have a lot of those other symptoms in the other page. So they have redness, swelling, smell, drainage, warmth, pain, all kind of in one. And then especially if they have red streaking away from the wound, and then the patient's also endorsing feeling sick or unwell. Like sometimes people equate it to like they kind of like feel like they have the flu, like they just feel really run down, just terrible, and feels that the wound has gotten worse. They likely have been living with this wound or have had it for a bit. And so they're a lot more aware of when the wound has gotten worse than it has been in the past, or they're like, ah, yeah, it's back to the same as when I went to the ED before, because oftentimes they've been previously. So they have a good idea of when it's worsened and it's time to go. And so usually at that point, I kind of discuss, okay, how would you like, I want you to go to the ED. You're agreeing that you don't feel very good. How can we make that happen? How can I get you to the ER? And so that might look like, calling AMR for them, if they're up for that. Other times, if they're okay with it, like an Uber or a bus pass, depending on how ill they are. And then if they have other barriers, trying to I'll offer to call if they're worried about their housing or having a bed at one of the shelters, I'll offer to call. Very luckily here at CHAZ, we have options for respite beds, so I can, make that referral before they even go to the ED, so they know that hopefully they'll have a place on the way out. As well as, Providence and Multicare both partner with some of the local shelters to offer respite beds as well. So I'll tell the patient about that if they don't already know. Help arrange care for their pet. Or sometimes I'll kind of make deals of like, I know you got to go, figure out where your pet's going to go, where you're going to stay. if the clinic's open the next day, I'll be like, would you be agreeable to the next day? Like, I want you to go today, but if that ultimately cannot happen, like, would you be agreeable to go the next day? Like, come in tomorrow and I'll call the ambulance if they don't have the option to call themselves. And kind of try to just work out some way for me to get them up there. Other times I'll type up a little like page if they don't think they'll remember what they're going in for, or they don't think that like the nurses will take them seriously at the hospital or the ER. I will kind of write up a little like, this is what I'm worried about, for them to just hand to the triage nurse in the ER, so that they kind of they'll have to try to explain it all over again, which can be very frustrating, especially if they are having trouble kind of remembering what's going on. And then other times I'll call. There is kind of a peer-to-peer that the nurses have and providers have options to do, where I can call the ER and kind of let them know who's coming, when and why we're concerned, and sending them up to the emergency room. And oftentimes, very likely there's only been a few times where I haven't, a patient's refused, and it's been kind of concerning that maybe they aren't able to make their own decision regarding refusing, like they're just not with it entirely. And so at that point, I usually will, try to either call AMR and have AMR talk with them. I'll bring in other coworkers to see if maybe they can kind of work out getting them over to the ER and kind of explain it better than I am to the patient, figure out what extra barriers there are, or you can always get DCR involved, which I don't ever really like to do that one. I don't want to burn any relationships, but if you are concerned about a patient's well-being, that is an option, unfortunately. But these pictures, so this one and the one on the slide earlier, are kind of good representations of what redness can look like on lighter skin. But I always like to kind of plug in that on darker skin tones, redness and irritation can kind of look different. So it can, appear reddish, purple, or just a darker brown. So I always kind of like to compare the limbs or the skin on a different part of their body that's not affected, to make sure that the skin tones match when they're not appearing a different color. Or I'll ask the patient, does this kind of look normal to you? Some good resources for kind of picture examples of what wounds can look like on different skin tones is kind of Mind the Gap or Visual Diagnosis. They have some pictures in different skin conditions. And then this guy is just some picture differences that I wanted to kind of put up regarding what kind of redness, irritation, and swelling can look like on kind of a lighter skin tone versus a darker skin tone. And you can kind of see it is harder to tell the severity on a darker skin tone, and you have to kind of be using those extra cues to tell the severity on the darker skin tone. Like it's more swollen, you can see kind of a more darker area on their arm, and likely if you were to touch it, it would feel very warm. And so using those other kind of symptoms to watch out for can be important too. And then some of the supplies that we like to provide patients, just some generic basic wound care supplies, would be gloves, wipes, ways to clean their hands or make sure that their hand is kind of covered whenever they're doing dressing changes. Chucks, which are kind of absorbent pads or sheets that they can lay out to kind of create a clean surface. Adhesive gauze dressings of just different sizes, antibiotic ointment if they're not allergic. And then if we have kind of a bigger bag or extras, gauze wrap and tape. Oftentimes I'll give patients just a few days to a week worth of a supply, because sometimes, unfortunately they're not able to carry larger amounts with them, or it kind of gets lost in the shuffle. And so that also makes it so they kind of come back to see me for more supplies, which can kind of be a nice little point of contact with them just to see how they're doing. If they don't want to do wound care when they're picking up supplies, that's completely fine, but at least then I kind of have eyes on them and can kind of chat and see how they're doing and how they're feeling. And definitely kind of directing them to a healthcare professional can be useful because we can give them a little bit fancier supplies than these, very tailored to their specific wound. And if a patient's ever hesitant to put a dressing on a wound, that's usually completely okay. I just try to like talk with them and kind of see why they're not wanting to put a dressing on it, and see, if they're willing to try something different that I can work with them to kind of figure out. But ultimately, they're the ones that have to exist with the dressing on. So it never hurts my feeling if they're like, nope, that's not the thing for me. That doesn't work, or they want me to redo it. I'm always happy to do that because yeah, they have to live with the dressing longer than I do. I see them for an hour or two max, but they're the ones that have to kind of exist with it. So I definitely always, tell them, I'm like, let me know the next time I see you how it went. Like, did it work? Did it not? Do we hate it? That's fine. I'm never offended. I'm always just curious. I like to know what's working well and what's not. And then I kind of just briefly wanted to kind of touch upon some common wounds before we move on to our case study. I won't go too in depth into this just for the sake of time. I want to make sure we have enough time for questions at the end. But if we do have extra time, I'm happy to kind of revisit these. All of these are kind of common wounds that you may see with people with substance use and or unhoused. And so kind of some are weather related, frostbite and burns. These ones you do treat a little bit differently than with your basic wound care principles, at least at first. So kind of the biggest takeaway with frostbite and burns is if they just occurred or a patient hasn't been seen since they happened, I do recommend that they go up to the ER for evaluation. Treatment for these can look a little bit different than basic wound care principles, and it's important that they're evaluated as quickly as possible, just to make sure that there's no kind of hidden worsening wounds that can happen with these, especially at the beginning. And then trench foot, that's essentially just excess moisture and cold, kind of the medical term for it's macerated, but making the skin become really, really pruny and just soggy and wet. And so drying things out as quickly as possible can be super helpful, and not always easy to do depending on the weather and the situation that the patient is in for housing. But just making sure that they get lots of dry socks and have the opportunity to dry their feet out can be really helpful and evaluated by healthcare professional if needed. And then parasitosis, chronic wounds, and injection site wounds, all of those ones. Obviously, treating the cause is really helpful, but those ones kind of follow the basic wound care principles of, keeping it clean, keeping it covered, making sure it has the appropriate amount of moisture, and just kind of monitoring for signs and symptoms of infection. And kind of just working to kind of treat the causes can be kind of the most useful for those ones. And then we'll move over to Emily for the case study.
Perfect. Thank you. Okay, so just a little bit of background about my position is I've worked on the street medicine team as a nurse for about the last 2.5 years. I carry a caseload of patients that I see outside for outreach in transitional housing and then housed as well. And I do wound care on them anywhere from 2 to 3 times a week. So I get to talk to you about one of my favorite patients. I've been seeing him for about the last 2.5 years. And he has allowed me to share his story and kind of use his experience for this case study. So as we go through this case, I want to talk about the impact of polysubstance use on healing a wound, the challenges of access to care while living unhoused or with unstable housing, and the importance of harm reduction while building trust and promoting healing. So as we move through these slides, I want to keep these questions in the forefront. So what's getting in the way of care? How can we meet this person where they're at? And what does compassionate, realistic, and respectful care look like? Okay, heads up, the next one is going to be a picture. Okay, so this is our patient. So he is a 40-year-old male, history of polysubstance use. He chooses to use heroin, fentanyl, and meth. He does also have a history of schizoaffective disorder. We started to see him in clinic around 2021. Around that same time, he did get evicted from the apartment that he was staying at. And so street med kind of became involved. I have been seeing him since around 2023, 2024. We have been treating his leg wounds. He's got these kinds of chronic ulcers on his legs. He's had those for about the entire time that I've been seeing him, and the healing has really ebbed and flowed. And we'll kind of talk about why in a little while and what we've done to help treat that. So, starting the conversation regarding wound care can be a little intimidating, as Hailey talked about. So, we kind of just want to give you some tools about where to start because they can be such important building blocks to coming up with a wound care plan with your patient. So, we always like to set goals together, which Hailey did kind of touch on. So, their priority at this moment might not to be to heal the wound, and ultimately that is okay. It might be to avoid the ER, to reduce pain, to keep the wound from getting worse, or to stop it smelling so much. Again, healing might not be realistic or desirable. Always honor that existing knowledge. So this is someone who has possibly had this wound for quite a long time. A lot of our patients have had these wounds for well over a year, and they've been treating them on their own for quite a while. So always ask questions like about what they've done in the past. What have you tried to heal on your wound before? Have you noticed anything different about your wound lately? Was there anything that worked really well in the past that you would like to try again? And then ultimately just let them know that we are their ally. So we're here to support their choices and their comfort. We have the medical background, but they have the lived experience. In his case, his specific goals were to stop the smell. He expressed some embarrassment and discomfort about his wound. He wanted to heal the wound as best as we can. And then he wanted to learn to care for the wound himself. So his long-term goal was to gain confidence and then manage the wound independently with his own materials. Okay, so the plan was wound care visits twice weekly, dependent on availability and ability to outreach the patient. If we couldn't find him at his usual spot, we would actively outreach, and this would involve me as well as a couple of our team members who would just kind of search for him for a couple hours. We would give him enough supplies for 2 dressing changes at a time in case any visits were missed, since future access was always uncertain. And then I really want to highlight plan, especially plan in quotation marks. So a wound care plan for someone who is living on the street or with unstable housing isn't about perfection. It's about consistency and trust. So flexibility isn't the backup plan, it is the plan. So always keep that in mind. So barriers to wound care, I do want to talk about broader barriers, but first I would like to talk about his personal individualized barriers. So he was often very difficult to outreach and engage. We would find him, and so he would occasionally decline care, saying not today or he wasn't ready. And then just trying to find him, we would have a very difficult time no matter where we went. We would call shelters, look down streets. And he said, when I asked him about this one time, he said that sometimes I just don't want to be found. When we would find him, he might be flying a sign on the corner, so he would be reluctant to lose his spot or have others see his wound. His willingness to receive care was also often dependent on his mood and mental state. So many days he'd appear to be visibly disappointed or frustrated to see providers, even if he did ultimately accept care. And then he also has a long history of trauma and pain associated with his wound care. So he's been taking care of this a long time. He's had increased pain with it throughout the years. He's had healthcare providers that maybe didn't listen to him or would put wounds dressings on that would stick to his wounds. So even more pain with coming off. So he was really fearful to try new techniques in the beginning and new dressings in general. He also has underlying health issues that interfere with wound healing, which Hailey talked about a little bit prior to this. So in his case, the blood flow in his legs is compromised. And due to the environment that he was living in, I mean, lack of showers, staying on the streets, he was just always more susceptible to infection. He wouldn't allow providers to assess his wounds. He wanted antibiotics without assessment, but then he would be non-compliant with those antibiotics. And then he also has a history of polysubstance use and schizophrenia. So substances like fentanyl, meth, and heroin can constrict blood vessels, which slow wound healing. They can also suppress appetite, which leads to poor nutrition, which is critical in tissue repair. And then meth can lead to scratching and picking at the skin. A lot of the time when we would take off his dressing changes, he would reach down and really scratch his wound, which would just open up little more micro wounds around his already larger wound. Alrighty, so then broader barriers to wound care. So wound care isn't just clinical, it's structural, social, and personal. We have to recognize the daily barriers that our folks are facing every single day, like lack of stable housing, limited access to water and showers, food insecurity, lack of safe storage, constant displacement, stigma, and criminalization. Healthcare likely isn't going to be someone's top priority. They have a lot of other things that they're concerned about. So they have other needs that require attention first. So it's just important to meet somebody where they're at and what they're ready to do that day. We can't expect stability in someone's care when their world is unstable. So addressing barriers, and where do we start? It's always good to remember that respecting boundaries means supporting the entire person. So what else can I do to support this person if they are not wanting wound care this day? In this patient's case, he would have old socks and pants, and his pants and socks would constantly stick to his leg. So every time we would take them off, they would just kind of take some of that wound with them. So it was really important to supply him with new socks and new pants. And those are easy things that I can find for him in our outreach closet or go and get for him for fairly cheap. We want increased protein. We preach this to all of our patients, but he missed breakfast service. Is there a snack that I can get him? Is there a quick McDonald's that I can run by and just grab him a cheeseburger? A protein shake can go a long way. We carry a lot of those with us so that we can distribute them to patients. A patient has a wound, they are not their wound. So always treat the person first, and that wound care is going to follow. Increasing communication. So this is ultimately bigger than the wound. You're using this as a way to repair relationships with healthcare itself. So wound care is really personal. I am going to be touching you. You're going to be vulnerable with me, and often we're probably going to incite a little bit of pain. Our folks have a history of trauma, so wound care can trigger fear, shame, embarrassment, feelings of powerlessness, fight or flight responses. So always keep that in mind. So trauma-informed care and trauma-informed communication. So I am always asking for consent. I don't like to touch somebody without letting them know that I will be touching them first. I don't like to put cold saline or anything on a leg before cleaning without letting them know what it might feel like. Also just checking in about comfort throughout the entire visit. So making sure that they know that they can take a break if they ask. And then also validation and words of affirmation, I think are so important that sometimes can be missed. So just letting them know that we're really proud of them. They're doing a really great job. What they're doing is not easy. And then always offer choices when possible. So a lot of the time I'll hold up 2 different dressings that I think might work best for the patient, and I'll have them either feel or look at them so they can decide which ones they are wanting on the wound. A lot of the time, our folks have had poor experiences within our medical system. They felt dehumanized, they've lost trust in our healthcare providers. So by providing wound care, even if it's handing out a Band-Aid, we're opening that door back up and building a relationship. So it's a privilege to be that bridge back into healthcare and services. Please make the wound care fit into the patient's life versus the other way around. So the best dressing in the world means absolutely nothing if it causes pain, can't be changed easily, or won't be realistic in their living conditions. So we always like to offer portable supplies that are easy to carry. Waterproof bags are super important. It can be something as easy as like a little Ziploc bag. Something we've also done in the past, especially in the hot weather, is we'll have like empty water bottles. So people can put their supplies in the water bottles and then they can fill the water bottles up later. Something else to keep in mind is the conditions that somebody is living in. So is it 100 degrees outside? We're kind of starting to near summer. I mean, I think it's going to be like in the 90s today. So when we're wrapping those legs, we want to make sure we're not using tons of dressings that they're just going to have to take off later because it's too hot. Just a reminder, like, you are with the wound for 10 to 20 minutes. They are with that wound 24/7, so make it work for them. We also like to schedule wound care appointments around other priorities. So food banks, food services, MAT appointments, shelter curfews. Something we like to do a lot as an example is, hey, I know that you've got an appointment at DSHS tomorrow at noon. Can I meet you around 10:30 and I can bring you a bus pass so that you can get there after I do your wound care? And then always working collaboratively with community partners and SUD services. So collaboration is critical. I think that's why a lot of us are tuned in here today so that we can learn how to work together. Wound healing doesn't happen in isolation. So a lot of our patients, the starting point for wound care is also a starting point for re-engagement into services. A lot of our patients see caseworkers first and housing service providers and shelter workers. So those are the people that they're going to grow the closest with. So it's really important that you know the resources out there for medical and wound care, and we'll kind of plug, if you're in Spokane, some street medicine numbers and where you can reach us as well. And then on our side of things for healthcare providers, we gain that trust through wound care, and then we can kind of talk about housing services. Do you have a caseworker? We've kind of talked a little bit about your drug use. Have you ever thought about SDOH services? Okay, so where we are at with the patient today. So the picture on the left is the very first one. This was taken about 4 months ago. The one on the right was taken about 2 weeks ago. So we continue to outreach this patient and respect boundaries. We never pushed wound care on him. We met him when he was ready and he knew how to reach us when needed. We met him with other needs first, outreach supplies, bus passes, a snack or two when he needed it, socks, pants, as I mentioned before. A big turning point for him was he started working with housing and he got into transitional housing, where his wounds started to improve with access to food and showers and healthcare coordinators who were able to check on him every single day. Another huge plus was at this transitional housing, he got to see our street medicine providers every Friday and then the nurses every Tuesday. So he built up a really good trust and relationship with the street medicine team, which was helpful because a few months ago, he got evicted from the transitional housing due to some drug use on site, but we were able to maintain a very good relationship with him due to everything that we've built in the past several years. So when he went to his new place, he called us, he let us know where he was at, and we were able to continue the progress that we had made with him. Where he's at now, he's had a really great relationship with the staff. He is going to the methadone clinic every single day. He's got transportation there, which is huge. And we are able to see him now about 2 to 3 times weekly and are hopefully very, very close to healing that wound. Okay, so I'll bring Hailey back in and we'll kind of talk a little bit about the key takeaways.
Yeah, so some of the key takeaways really is just keep wound care simple. It doesn't have to be a super, super, fancy thing, but just making sure to help the patients keep their wounds clean, helping them control moisture, which is often just by, keeping it covered with a clean dressing, and then encouraging them to monitor and look at the wound, and making sure that they're just keeping an eye on the surrounding area as well. And then kind of recognizing when there are signs of infection and when to seek help, or encouraging the patient to seek help.
And then I just kind of want to leave with wound care is just as much about the trust and relationship that you build with someone as it is about healing the wound itself. So harm reduction first, healing isn't always the goal, and that's okay. You just really want to build that relationship with the patient so that you can continue to progress together.
All right. Any questions?
Okay, do you guys mind for questions on sharing your slides? That way we can just see you guys.
Yeah, we can stop sharing. Absolutely. Let's see. I wanted to get to we can share that at the end. So yeah. There we go.
Thank you. Does anybody have any questions for Emily and Hailey? I do want to just real quick. I love that you guys talk about addressing, repairing the healthcare relationship. I think it's very powerful for you guys just to recognize that and ask permission and just know that people have trauma with healthcare and you're basically building that bridge. And so I love that. Just want to point that out.
Yeah, we're happy to take any questions at all.
If anyone is in Spokane as well that is watching this and working in services, we do have a provider line. Chaz Street Medicine works Monday through Saturday now. We're trying to bump up to having 2 teams out at a time. There is a provider line that goes straight to one of our providers who is on at that time. It is monitored from about, I would probably say 7 a.m. till about 5 p.m. We do try to respond that same day. If we can't respond the same day, we usually can get there the second. But someone will usually always answer that call. It also accepts text messages.
What is that provider line? So I can put it in the chat.
Yes, so that provider line is 509-481-3152.
Yeah, thank you for doing that.
And I will also share that with the SOAR Hub and spoke people here in
Yeah, thank you.
Spokane, just because I know you guys are out there doing the work with most of their patients. And so
Yeah, that would be wonderful. Thank you. And we're happy to, like, if you call us anytime, we're happy to take the calls. Nothing is too small.
perfect. Perfect. Did anybody have any questions? You guys were also very thorough, so if there's no questions, that says a lot about your presentation. But
I'll take it.
what do you recommend for folks who are not clinical for supporting people who use drugs who also have wounds?
Again, it always kind of just goes back to building that relationship. Because I feel like that's typically gonna be the case. There's gonna be a lot of non-medical people meeting those people with wounds for the very first time. And a lot of the time we learn that they've had these wounds for quite a while, and it took them like a month or a couple weeks to like actually show the wound to that person. So I feel like it always just kind of goes back to relationship building. And then just to kind of have what Hailey said in your back pocket a little bit. So you can have kind of the band-aids and the ointments and stuff, but I would really recommend just building that relationship and then possibly if you can, either calling us or getting them into urgent care, or if you're in Spokane, the Providence Community Clinic is also a great resource.
Yeah, and oh, I had it and I lost it. Yeah, I mean, we don't ever have any sort of instances where, you know, we won't see someone because they're using drugs. Like we're happy to see somebody and treat their wound, and then also kind of just that's not any sort of kind of disqualifier at all. And so just kind of letting them know, like, I'm happy to see you and treat your wound or get you to someone who can, and that, you know, we can work on that. And what supplies you put into the kits you give out. And so we usually just do like band-aids, triple antibiotics. We try to do like a variety of band-aid sizes. So like some of the like bigger ones and then some of the small ones and then some of the like knuckle bandage ones. Because those are pretty basic just to cover any sort of small wounds that they have. And if they have bigger ones, kind of just working with them to try to get them in to kind of see a healthcare professional. Because I give out lots of supplies at the clinic that I work at. So if someone has a bigger wound, I'm giving them at least a week supply in like a big old shopping bag, just so that they have that ability to do it on their own. Because I know not everybody can make it into clinic multiple days a week. I don't even know if I could do that, quite honestly. Commit to that.
Well, and like when I was on the streets, people would get wound care kits and then they would share them with their friends. And so it wasn't just their wounds that they were tending to, they were helping other people tend to their wounds as well. So that's great. What has your caseload looked like in terms of reoccurring wounds or long-term clients? And what has your success been? Do you track over time or just as needed intervention?
That's a good question. We were kind of just talking about this today, actually. Like this presentation has opened a lot about us kind of looking like our history of clients and patients and our caseload. I think since okay, so the caseload I would say for the last 6 to 8 months has grown quite a bit. I don't know if that's just because our team personally on street medicine, we gained another nurse, which was able to open up the amount of people that we saw. We've also been doing a lot more outreach, which has been really helpful. So we've been able to kind of find people. So I would say we have been seeing a lot of the same patients for well over 4 months now. So a lot of our time is spent just outreaching and trying to find them out in the community, at the shelters, at the transitional housing. Our success, I feel like that ebbs and flows so much. There are a few that I can kind of think of like outliers that have healed pretty well. But I would say for a lot of our patients, it's been kind of like a labor of love a little bit. So we've been seeing them for the past like 4 to 5 months, and I feel like we are making progress. It's just kind of a little bit more difficult just because of all of those kinds of like existing factors, but we are slowly making progress. And I think a huge win too is that the wound is not getting any worse. I think that's a huge win. So we kind of try to keep that in mind. But I can think of a few people that we were just talking about today where we have gotten their wound from like this size to now just teeny tiny. I think we're almost done kind of seeing them for wound care for the moment.
No, that is awesome.
Yeah, it's really awesome.
Your success of like, it's not getting bigger. Like it really is, especially if somebody's on the streets, because there's not places to clean it and stuff. So I feel like that's success.
Yeah,
So
and then like another like huge measurement of success, which I kind of talked about at the last conference, was just a lot of our patients, after talking to them for this long, now reach out to us, which is huge, which is so cool. It's not something that I like would expect one patient to do, but they'll go into Chaz or they'll call in and say, "Hey, I really need to see my nurses today." And that's also a huge level of success that they feel comfortable enough with us to know when they need help and to call and to reach out first. So that's been huge and that's been really exciting.
that's awesome.
Yeah.
Not a question, but a compliment. Somebody says, "Thank you so much. As a nurse who used to work in a shelter setting, that's really fantastic wound healing in 4 months, and it's really inspiring."
That's awesome. Thank you. We're very proud and proud of the patient.
Yes, it really is like that. It looks so good. Even
Yeah.
like, I don't think you had that last picture at the conference
Mhm.
to go. And so I like the update. I like seeing the more healed picture.
Yes,
So
I do want to mention something too that kind of also at the last conference brought up because you guys were talking a lot about contingency management. And we kind of do that in our own little way. So with that patient, especially something that worked really, really well for him, and luckily we were able to do this, but he loves coffee. Loves, 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 loves it. Does not buy it for himself. He doesn't have great coffee at the shelter that he's staying at. So something that we've worked out with him is I bring him one iced coffee every Thursday if he gets his wound care done twice a week. So if he gets his wound care done Tuesday, I will bring him his coffee and do wound care on Thursday. And that has worked incredibly well as well. So it's kind of our own little version of like contingency management.
no, that's awesome. Yeah, no, that's really cool. Perfect. Is there any other questions or comments? Thank you for the work you have been doing, and thank you for sharing your experiences and insights. We really appreciate both of you coming on here and at the conference and sharing the work. And it's just awesome. It's awesome to see in Spokane. You guys are very rare around here. And so we appreciate you.
Yeah, well, thank you for having us.
Yeah,
Yes,
thanks.
Yeah, it's
thank
been
you.
fun.
Maureen, do you want to take on
Yeah.
over?
Yes, I'm going to share my screen and I'm going to share their last slide so that Emily and Hailey can give a little information about themselves because I know they wanted to do that. And then I'm going to share some upcoming trainings. So Emily and Hailey, feel free to let us know how to reach you.
I think for me, so that is my work cell phone. So much like the provider line, please call it, text it. I am handing my number out like crazy. I do not mind if I don't respond to you that day, I'll respond to you the next day. But either that or my email, but I would love to come triage any wounds. Just let me know, or if you have any questions about outreach.
Yeah, and I'm less out and about. I'm mainly at the Chaz Denny Murphy location. So if you have any patients that go there, I'm always that nurse on Fridays. But for the most part, my email is the best way to contact me. But if you have any, questions or wanna chat, I'm always happy to really discuss anything wound care or patient related.
Hailey is like a plethora of wound care knowledge. I'm constantly messaging her about everything, so I just want to plug that as well. Very knowledgeable.
Thank you.
Thank you both again, and thank you for offering to share your expertise with folks on this call. We really appreciate it. I'm gonna just go over what's to come next week and some upcoming other educational stuff from our team. So next week on Monday, same time, same place, we're going to have a Dr. Danny Hidano from Harborview Medical Center talk to us about cardiovascular considerations for people who use methamphetamine. And then we have our standing trainings in June on the 18th for the nurse care manager call. We have someone from King County Public Health who will be presenting on the topic of stigma and MOUD care for the nurse care manager advanced topics series. So if you're interested in joining, please register. The quarterly emergency department call with Dr. Chris Burish will be happening again in July on the 4th Tuesday. And then the call that Mark Duncan and I do, caring for patients in the era of fentanyl, is happening again in August on the first Wednesday of the month. And we'll have a panel talking about updates on access to methadone. And then we have our monthly call series, the monthly jail call series, or monthly jail call is actually tomorrow, facilitated by Dr. Mandy Owens. The monthly care navigator call is happening on Wednesday with our own LeiLani Dawn, who's here today. And then the monthly adolescent opioid use disorder call will be happening on June 18th. And that's facilitated by Addie Adwell and Alexis Ball. And then I just want to share some resources from ADAI, and I highlighted the Focus on Meth website. That's a website that houses a lot previous webinars on the topic of methamphetamine and methamphetamine use. The recordings from these trainings will end up there, as well as on learnabouttreatment.org. And previous recordings for ADAI's 2025 Focus on Meth series are already there. And we want to again thank you all for joining us today. Thank you, Emily and Hailey. Again, it was such a pleasure to see your faces again. I hope you all have a wonderful rest of the day.